start from the end. Since we're talking about registries, and specifically for Rudy,
yes.
Since it's not specific to FDMAS, how many people come in who don't know they have FDMAS and finally figure it out? Related to this, what is the rate of lack of diagnosis? Do we know how many patients are we missing? And where are they, and how would you find them?
Very big question. The only way to truly find them would be to give everyone an isotope bone scan, because we don't know how many asymptomatic monostotic lesions there are. And if they're not painful, then they're not clinical having an impact. The main probable cliff edge is orthopedic surgeons who diagnose fibrous dysplasia and tell patients, don't worry about it, it's not going to bother you. It's not why you've got a painful arm, which we see regularly in the UK and probably in other countries as well. Or maybe not, maybe orthopedic surgeons are different. Anyone want to add to that?
Yeah, I think it's difficult too to categorize them because, again, to your point, there are probably many people with a diagnosis of monostotic FD who have not had a bone scan and may not know the full extent of their disease. So it just raises some of the challenges of the self-reported registries.
Great. Next question.
Yeah, thank you. I wanted to wait for everyone who's been working on denosumab and pain on the stage, but have you considered treating denosumab with maybe a combination of a low-dose analgesic? Because it's fairly likely that there's multiple mechanisms at play, and so treating one side might reduce it a little bit, but doing multiple.
Yeah, I'll just answer briefly because, you know, I think there's multiple, and then I'll hand over to Natasha, who is studying this more carefully. But, you know, I do think when we talk about denosumab, it's important to focus on the multiple potential uses of it. Personally, although I would love for it to be an effective pain treatment, I think what's potentially more powerful use is its ability to change the lesional composition and endpoints related to that. So we have not used it with the primary goal of reducing pain, although that is wonderful. So our patients have continued to use typical pain treatments when they do have painful lesions, which is not most of them. You know, I think we focus a lot on pain, but it is important to highlight that many FD patients do not have significant pain. It's a kind of a wide variety.
Oh, and I think also in the design of the trials, because patients need to have a certain pain score before entering the trial. Of course, when somebody reports a pain score of 7, but does not use any analgesics, we will first make that approach to see if we can lower the pain scores with that, because then there might not be a necessity to enter the trial. And when they enter in the trial, they are continued on their pain medication. So we only looking at them if they can reduce the pain medication. So we are treating it in a combined way. And of course, when there is a neuropathic component, most likely denosumab will not work on that. So you will also make additive measures to treat that part as well.
Okay, another question? Yep, behind you.
Hi, I just wanted to. So we had today reports from 3 different centers on the use of sodium fluoride bone scanning and studying fibrous dysplasia. And everyone highlighted the different features of it and also highlighted the amount of data you can get from it, the complexity. And I would advocate that really the leading centers in all of the groups come together and develop a unified way of analyzing fibrous dysplasia with sodium fluoride bone scans.
No, I was thinking exactly the same thing, Mike, when Alison was also presenting, of course. I think it would be great to have a look at not only the nuclear medicine part from it, but also perhaps in collaboration with Roland on the outcomes of the lesional size, the bone mineral components with the CT scans. Because I think what we've also learned a lot is that you can measure so many things on the sodium fluoride PET scanning. You can also easily get lost in what's relevant and what's not. And what we've also seen is that people use different types of mechanisms on how to measure, because it also depends on the scanning type. So we learned from our own mistakes, because in the beginning when we first did those scans, because they were in clinical care, there was a lot of difference in the time in between the scanning period and the giving of the medication. So that also alters your outcomes. So one of the things that we now have done is that we standardize all the things. You have to standardize, of course, according to the healthy bone tissue and the change you can measure there. So I think I foresee another big mutual project.
Yeah, Mike, I do agree, and I think that we have to do a work of standardization of the approach, and that this should be a standard procedure when we start taking care of a patient and then in monitoring. And also, I would like to complete the question you asked me a moment ago regarding the evaluation in CT. The CT they use when they do the fluoride PET scan has not the same resolution than the usual CT. So we have to think about that because when we do a repeated measurements with CT, and this could be a problem if you want to do fundamental analysis to estimate the bone strength. And to do the FEA model, in general, we like to have a better resolution, but the price to pay is, of course, an increased X-ray exposure. So this is probably a thing we have to talk about and think and reach a consensus.
Actually, I wanted to go back to your comments, because I totally agree with what you were saying. But the one thing I wanted to throw in there is also as you think about pediatric trials, the exposure to radiation is a whole different ballgame when you talk about doing this in children. But the question that I actually had is a little bit different. One of the things that struck me looking at the scans that we were presented, when you treat with denosumab, you have this reduction in lesion activity. You mentioned that one of your patients felt that her leg was really warm and that warmth went down. I mean, the obvious thing to me is that there is an incredible amount of metabolism that's through the roof that is going on in those lesions. One way to image this is using not sodium fluoride PET, but something called FDG PET. And I'm wondering whether this is a place where looking at the mouse models of fibrous dysplasia, where you can do lots and lots of things without having to worry too much about radiation dose, as long as you don't start also affecting the mouse in other ways. So you have to be smart about it. But actually in FOP, we did both. In the mouse model, I don't know if we published our FDG PET, but we compared FDG PET with sodium fluoride PET. And it's really, really interesting, because what the FDG PET told us is that in the very early beginnings of our lesions, which are basically modeling lesions, they're not remodeling, it's de novo endochondral ossification, which is, I think, quite different from FD. The FDG, the metabolic signal, is really, really quick, really obvious, and it just goes through the roof, and it precedes anything you're going to see from sodium fluoride PET. Now, I don't know if that's really useful or not, but I wanted to throw it out there, because I do think that the metabolic aspect of this disease has been underexplored, if I can say something like this without offending anyone. And there might be something to it. There might be something. Part of the reason maybe you don't see a reduction in the lesion volume might have something to do with the fact that you may or not be affecting the metabolism to the effect that you should. Something to think about.
So Eris, why didn't you use FDG PET in the FOP trials then?
Do I look like a clinician? I don't make those decisions.
No, I think it's also important to highlight it, and I think it's a good comment, because what we've seen, we have seen accidentally being PET scans being made in patients for different ways, because a lot of the patients first get a diagnosis that it might be a malignant tumor, and once that is out in the open, people go through a PET scan before they receive anything. So we do have a lot of our patients who have received PET scanning in the past. And there you can see that there's a difference between the activity of the lesion. So we do see that when we're doing bone scintigraphy or a sodium fluoride PET scanning, that you probably will notice more lesions than when you're just doing a glucose PET scan. And what that means, I think we still have to explore that. But we do see the difference that the sodium fluoride PET scanning is way more sensitive in picking up everything. But the glucose PET is also, in some of the lesions, very active. Especially in the craniofacial ones, but in the axial skeleton, it's less, in the long bones, also less active. But there is something to explore there as well. But there's a lot to explore, I think, on this field.
I have two related questions to the denosumab trials. The first is very naive, actually. So I understood that FD grows a lot the lesions when you are perhaps a child, but in adulthood it stabilizes. So it sounds like you could give denosumab early in life and stop giving it when it stabilizes. However, the trials are done in adults and they show rebounds when you stop, when I was expecting that the lesion wasn't anymore that active anymore. So will that really happen? Would you predict that you can stop giving denosumab at 20 or so? And the related question to that is, if you have looked at the other bones that don't have deletion, and do you get too much bone density because of not having osteoclast? What happens there? Thanks.
Yeah, great question, and it highlights a lot of the complexity of managing particularly pediatric onset metabolic bone disorders throughout the lifespan. So in FD, I mean, you're absolutely right that the process by which the lesions are initially develop and expand appears to be a pediatric process. However, the morbidity that results from those lesions persists throughout the lifespan. So I think one difficulty in this field, or one challenge for us, is we're going to have to figure out what are the specific indications for using denosumab, and there's going to be a wide variety of them. I hope that one of them may be to prevent disease burden from becoming established in children, and if that is the primary goal, ultimately we hope that we may potentially be able to stop denosumab in late adolescence or early adulthood. That's actually a similar treatment approach we take in osteogenesis imperfecta, where, because anti-resorptives in general are more potent in the pediatric population. So in that disorder, we treat growing bone, and then we start at birth, we stop in late adolescence. However, there certainly will be indication to use lesion-altering medications in adults, depending on the causes of morbidity. In our adult trial, again, it was almost difficult to capture the functional benefits because they varied so much from patient to patient. We had pulmonary function in one, vision preservation in another, mobility in another. So it'll have to be highly individualized.
I don't know if your question also was asking about the rebound effect, and why he's asking why in adults you see rebound after cessation. I don't know if you wanted to comment. Well, and I think one thing that's important to notice is that denosumab affects all of the bones, even the normal ones and not the FD ones. And even when denosumab was originally approved for osteoporosis, even in patients who otherwise don't have FD or any other metabolic bone disorder but do have osteoporosis, also can exhibit rebound after denosumab cessation.
There's two authors. So Eric Erickson is doing some really cool work where he's tapering the dose of denosumab. So in osteoporosis, so he's saying don't stop it, just taper it. So he's going from 60 to 30 and then down to 15, and that seems to a very small sample size. And then there's a work of Serge Ferrari, who actually showed it's what you give before you start the denosumab that makes a difference. So if you pile in lots of bisphosphonates and then start the denosumab, the off effect is mitigated a little bit. It's not 100%, but those are other treatment strategies, because we know just giving bisphosphonates when you stop denosumab in osteoporosis doesn't really work.
Yeah, I was planning on highlighting the same work. But also, I think what is also important is that besides the tapering, there's also some space in between that you can play a bit with the dosing interval, because we know from other bone problems, like bone tumors, like giant cell tumors, where the dosing is quite high with even weekly doses of denosumab, Xgeva, is that you can safely extend then the interval in between, but not too long, because like we've shown, of course, the rebound phenomenon comes back again. So that there's also something that we can play with. And I think what we also know is that the duration of the use of denosumab is very important for the rebound phenomenon. So the longer you take it in osteoporosis, the more injections you had, the higher the rebound will be. And it will bound to be the same, I think, in fibrous dysplasia. So we need, yeah, if you want to give it, I think in the end, perhaps in the end we will, you will like to give it a short time frame as possible to reduce those possibilities.
Beyond the overshoot in bone turnover, I have another concern on the use of denosumab in children, that is development of the immune system. So rank ligand is not specific to the bone. It's very important in the development of lymph nodes and thymus. And well, I believe there is no increase in the risk of infections and so on in adults, but in children, I think we need some more data. And so do you have some sort of monitoring of the immune system in your trials in children?
Yeah, I know there was a lot of interest in the role of rank ligand in the immune system and potential effects on infections, particularly when denosumab was initially developed. And at this point, in adults, Xgeva has been used at very high doses in very immunocompromised individuals, and has been shown fairly robustly not to be associated with an increased risk of infections. Probably the largest pediatric population that has been given denosumab, again, is pediatric giant cell tumors, who are given extremely high doses. Also are a generally fairly sick population, have not been shown to have an increased risk of infection. So although, of course, I'm concerned about everything related to denosumab treatment in children, I think there's no compelling evidence to be particularly worried about that. We will certainly monitor for it as we will monitor for all adverse effects. We check CBC levels, but no specific detailed immune phenotyping will be done on the study.
So Alison, I mean, they identified the rank ligand, I think, by looking at T-cell genetics. It came from the immune system, and T cells have a very important role in vaccine response and other things. So it may not be that hard, actually, to look at the immune, just to reassure what Roland's point is, because he is right. Denosumab actually grew from immunology rather than from the skeleton. But that's something just to think about.
Yeah, no, that's a great point. But then I want to highlight this medication has been given to many, many, many adults. So I'm not sure we are going to find true pediatric specific answers with our 15-patient trial or any of the pediatric trials.
But you can address Kasim's question by looking at vaccine responses in adults that are on chronic use of denosumab. That should be foundable. You just have to measure the T-cell response to the particular vaccine. Yeah, so that is foundable.
It's a good
okay,
point.
Just get someone to do that. I actually wanted to continue on. I'm the boss at my lab, so that's how it is. Seriously, the rebound phenomenon is due to this kind of pre-osteoclast that accumulates. It's called an osteomorph. That's the term that is used now in the field. And maybe you're a little skeptical about that research. I think it's actually quite well done.
No, I'm not skeptical. It's just it's one of the mechanisms. So Serge Farrar in Bente Langdon has done a beautiful piece. I think it's in JCI. Is it? There are 4 mechanisms for the rebound, and osteomorphs are definitely part of the story.
Well, I was wondering whether they have been looked at specifically in FD lesions. Since you do look at lesions, have you looked at the presence of osteomorphs post-denosumab? Particularly in FD, osteomorphs are one of the mechanisms. Maybe that's something worth looking at.
No, I think that's an excellent idea. I think trying to identify what the risk factors would be for a robust rebound would be really important, and FD is a fantastic model to do that in.
Yeah, this is Ed Chow, UCSF. Thanks very much for all of this interesting discussion. I don't know if you have enough data yet from sort of long-term follow-up for the patients that have come off of denosumab. As you know, one of the risks of long-term denosumab therapy, at least in osteoporosis patients, is spinal compression fractures, especially after withdrawal. Is there any information about that and potential risks, especially since you're using higher doses in some of the studies?
We looked and did not see any. What about you, Natasha?
We have not seen any problems with spinal compression fractures after treatment stopping.
I think that's a really important point, but don't forget those are spinal fractures in people with osteoporosis. So they have weak bones already, and you make them stronger, and then you take it away. So I think it's, I have a few patients, I have to warn them that it's not going to happen, definitely, because that was in osteoporosis people who get spinal fractures anyway. FD patients don't usually, unless something very unusual happens, get spinal fractures when I wasn't expecting it to happen.
So the only thing is that there were also a lot of studies performed in women, of course, with breast cancer and higher doses of denosumab use. And there, unfortunately, we have seen patients with normal BMDs before starting on the DMAP, which then came off without an exit strategy, who did develop vertebral fractures. But I also have to highlight there that those are women, of course, above the age of 50. But then again had a normal bone mass density measurement before starting on DMAP. So I think it is something that we are very wary of, and we take it into account, and we screen our patients. And of course, when I have a patient, adult patient who has osteoporosis over low bone density, so we do an exit strategy there. But I think this also highlights the fact that I think the use of denosumab in fibrous dysplasia has still a lot of questions, and therefore I would really want to emphasize, despite the fact that we're presenting all these studies that look promising, I do think patients should either get it in a study setting or in a true expert center where there's enough knowledge about how this works. Because what I also highlighted, you see so many case reports on the patients who were started on a drug and then it was discontinued and all these crazy things happen. And I think, well, if this patient was seen in an expert center, or at least there was some expert involved in the treatment, this can still happen, of course, but the chances are much lower that it happens, I think. But I'm also looking to the right side there.
Round of applause for the speakers.